Hello, everyone, and welcome to today's webinar, Transforming Healthcare Education, Strategies for Genuine Inclusivity. My name is Dr. Ilon Rincon Portas, and I'm going to be the moderator for this super important discussion. I am very grateful for everybody joining us today. As we all know, healthcare education plays a really critical role in shaping the future of patient care. But I do think that inclusivity has been overlooked for many, many years in many different ways. And so today we are going to explore how embracing real inclusivity can lead to better healthcare education and ultimately what we're all here for, right? Better patient outcomes. I am joined today here with an incredible panel of experts who are going to bring their insights and their experience to this conversation. So I would like for each one of us for each one of you in the panel to please introduce yourself if you can shortly. I know they can read your bios after, but I am so happy and so honored to be here with all of you. Maybe we can start with Dr. Hunter, if you want to introduce yourself.
Yes, I'm Dr. Teresa Hunter, and I serve as the Dean for the School of Nursing and Health Professions at Langston University, where we have a healthcare administration program, public health, and nursing program at the Langston campus. We also have nursing and at Tulsa and in Ardmore. So thank
You,
you.
Dr. Hunter. Thank you. Welcome. Dr. Alexander.
Good morning. My name is Dr. Karen Alexander, and I am the Director of Nursing at University of Houston Clear Lake in Houston, Texas. And I am Director over all nursing, undergraduate, graduate, as well as community education programs for nurses as well. I am 22 years retired Air Force, and I do a lot of research in the area of vulnerable populations. So I am very excited to be here today.
Thank you. Thank you so much. Dr. Array.
Yeah, hello. Hi, my name is Dr. Array. I've been a longtime faculty at Kaplan for surgery and neurology. I am a general surgeon and breast oncoplastic surgeon as well. I'm also a member of the United States Army, like some of the panelists who are retired or previously served. And I'm stationed in Atlanta at Grady Hospital, and I'm with Morehouse School of Medicine as well. So I'm happy to be here. Thank you all.
Thank you. Thank you for being here. Dr. Ketchy.
Hello, everyone. I am Dr. Kechi Hedru Anderson. I teach at Central Michigan University, and I am the director of the RN to BSN program. I am excited to be here with all of you.
Thank you. And last but not least, Dr. Langley.
Hello. I'm Dr. Seth Langley. I am the Associate Vice President of Student Academic Services and Academic Affairs at SUNY Downstate Health Sciences University in Brooklyn, where I oversee all the academic support and counseling services for students enrolled in College of Medicine, Nursing, Health Professions, Public Health, and the School of Graduate Studies. So I'm also a faculty member and an educational psychologist. So I'm excited about this opportunity to learn and share with you all.
Yes. Likewise, I am so incredibly excited about this. And so to get us started, I'm going to ask a question, and maybe I will ask Dr. Hunter to answer this one first. I will, let's have a really good conversation. If you can add real examples of what you're feeling, what you're saying, I think that is always great for our audience. Okay, and so Dr. Hunter, I wanted to start with you because when we talk about diversity, what is really genuine inclusivity in healthcare? Is we know that a lot of institutions have sort of checklists and stuff like that, but what does it look like when it's for real? You're muted. So.
Okay, for me, genuine inclusivity in the context of healthcare education does refer to a comprehensive and a thoughtful approach to ensuring that all students, regardless of their background, their identity, or abilities are given equal opportunities to succeed, and also to contribute to the healthcare field. It really goes beyond simple diversity or representation, and it aims to integrate inclusivity into the core values, the practices, the policies of healthcare education. Some of the things that would be helpful is representation of diverse perspectives. We need to include in our teaching cultural competence. Healthcare education should actively represent a variety of cultural, racial, ethnic, socioeconomic, and gender backgrounds. This will help prepare our students to deliver care in a way that is sensitive to the needs of diverse patient populations. Another one that I believe that we need to do is to do a curriculum that reflects inclusivity. Inclusive teaching methods. Educators should employ diverse teaching methods that center or cater to various learning styles. We all know that all students, all people don't learn in the same way. So some of the things that would be helpful is things that are interactive, case studies, peer discussions. We have to use digital resources. We can't always stand in front of our students and become talking heads and expect them to really have an understanding. They need to be involved. And we also need to involve that diverse patient experience into what we're teaching. And the last one I want to mention is supportive learning environments. A safe and respectful atmosphere. Our students should not be afraid to ask questions. They should be comfortable and they should be respected. This means creating an open dialogue. Sometimes this is about difficult topics like race, gender, healthcare inequalities without the fear of discrimination.
Thank you, Dr. Hunter. That's a really very, complete overlook on different aspects of what I think real diversity looks like. Dr. Array, I see you nodding. Do you have any follow-ups that you would like to add, or anyone else? Please come up mute and join.
Yeah, no, Dr. Hunter, that was very thorough. As you were talking, for some reason, I just kept on thinking about in the surgical sphere, something that we face a lot is educating, training residents or medical students who are of color, how to get them to feel like they're part of our group. There's so many barriers that we have to go through, and so there's this term that we've used sometimes called tokenization. Like, we're not just here to just create and say, oh, we're choosing you because you fit us or because you are of color and you want to be a surgeon. It's more of like you have earned it. And it's not really the selection people. It's more of when the students that have made those achievements, how they feel when they show up to work. And you have the students who do so well, who excel in every aspect, and then they show up to an um, all white leadership course of society, and they're treated differently. Or someone say, "Oh yeah, you're here because of the color of your skin," but no, like these students have earned your way to be here, but it just never goes away. So that for some reason, that's what I was thinking about some of our students and residents, and even some of our Kaplan students, what they go
Yeah.
through when on service.
Yeah. Great point. Dr. Alexander, I see you're.
Yeah, I was listening to both perspectives, and I truly agree. And I also wanted to add, especially when Dr. Array spoke about what he just said, that we often confuse inclusivity with DEI, and it is not the same thing. We want to think about inclusivity as making someone feel truly welcomed, right? And respected and supported. And for years, we have done this with historically marginalized groups where we say this is DEI, and it is not. It's a commitment to allow people to have diverse voices, to actively be included in the decision making, and not just think about we are trying to meet quotas or we're trying to meet diversity goals. So I just really wanted to add that to it, because I think that's very important, and that we think about integrating diverse perspectives and providing equitable resources and fostering that sense of belonging and removing these barriers, because a lot of times this is why students in any arena end up with mental health issues because of this same situation, and they're made to feel marginalized.
Agreed.
One last thing to that is that, along with what Dr. Alexander was saying, we got to think about this more than about meeting legal and ethical requirements, because sometimes we will do this so we can just check the box. And we got to get beyond checking the box.
Agreed. Dr. Ketchy, I think you wanted to say something.
Yeah, if I may just add to that, I think I was nodding my head when Dr. Ray was talking about tokenism, but I also wanted to add that, is the broader, health insight from different perspectives, right? You need to get those perspectives. Even for those who would say, oh, well, we don't have diverse students because we live in rural area, all our students are white, or all our faculty are white because we can't get diversity. But the point is, your teaching has to have to be, inclusive, because you're preparing the students to go out into the world and be, global citizens. They have to be able to provide care, communicate with individuals whose cultural perspectives are different. So really including those different perspectives and diverse perspectives in your teaching is really, really crucial. Minding the examples you use in the classroom, making sure that they are diverse. The images you use for examples, the case studies you use for your classrooms should be something. That's part of the ways that you have those perspectives. And know when you said about tokenism, and I was nodding my head and smiling, symbolic gesture of having one person of color or one person of LGBTQ plus community in your leadership or in your institution, that is not inclusivity. That is tokenism. It's a gesture to show that there's somebody there who is different from everybody else. Real inclusivity really is embracing those diverse perspectives. Is their voice heard in the classrooms? Is their voice heard in the meetings, in the policy? Are they considered? And it is a continuous process. There is no, we have achieved inclusivity now, right? It is a continuous process, and there has to be institutional commitment to the process. So it is an ongoing process. You're continuously learning, assessing, changing, and building on it. There is no apex to where you want to reach in terms of inclusivity. It is a work in progress, but the commitment needs to be there that you keep progressing.
I just wanted to piggyback on Dr. Anderson, Dr. Kelechi's point. Now, that was well received in that I was noticing the poll results, and student access was one of the lower statistical representations there. I saw other as being the lowest in terms of interest of what people focus on. And I wanted to just step back as I was thinking about and reflecting on that poll, the difference between diversity and inclusion from an operational standpoint in terms of defining it. The key thing I think of in terms of inclusion is a practice. The thing that I think of in terms of diversity is the condition of being different. So how do we move from taking a curriculum or taking a set of practices that have been in place in some cases for many, many years and adjusting it to be different and be mindful of the different perspectives that students have? And a lot of times students aren't supported, residents aren't supported because they feel that lack of practice. And so they develop a learned helplessness mindset and they just push through. I'm simply just going to do the best I can because nothing's going to change, And so I think we have to be mindful of the basic fundamental definitions in order to move forward and advance our adjustment in terms of how we respond to these two terms.
Super interesting, and I couldn't agree more. I was also noticing the poll results, and one thing that I have, it's a question that I get sometimes when we're talking about these. Why is this important? Why are we spending time, energy, and all of this, why is it so important for healthcare to be diverse? Anybody wants to?
I can say something to that because I was just thinking that when we were in the midst of this conversation. And when we think about curriculum and we think about inclusiveness and we think about culturally responsive, one of the things that we have to think about too is it is the job of students. It's one of their most important skills that they be culturally aware and productive in their environment because our environment is so diverse. So whether we're going to talk about medical students or we're going to talk about nursing students or any kind of healthcare student, when we're talking about curriculum and teaching methods, not only do they have to be inclusive and culturally responsive, we also have to follow, which we're tasked with, we have to follow the accreditation agencies, the essentials, the boards of nursing. But what we seem to fall short on sometimes is making sure that in these curriculums, we integrate diverse perspectives, that we include content that reflects the cultural, the social, economic, the ethic, diversity, and the patients and healthcare issues. And we talk about that all the time. And I always try to make sure that in my curriculum that DOH is in that curriculum, social determinants of health, because the stereotypes, right? The perceptions that people have of us, a lot of that is also in some of the accrediting agencies, some of the guidelines that they have us following. And so it doesn't allow for that cultural competence training. It doesn't allow us to incorporate the perspectives of diverse faculty, because that's another thing, having diverse faculty. And we know there are low numbers of diverse faculty when we talk about BIPOC. And then role models. And then another thing that we sometimes don't look at is our own, we get feedback from students. We get reflections from the students, but do we do our own reflections? Do we gather our own feedback? So when you said about examples, I wanted to give an example at our university about a couple of years ago, and it's a 5-year plan, I believe, that we have for QEP, and we call it Becoming Aware. Cultural interactions at UHCL. And so I have been very privileged to now lead with my colleagues to teach this is now the 5th cohort. And what it does, it aims to help students develop these qualities and to develop vital skills that they need. But as part of the plan for these students, we, the faculty and the staff, we participate in engaging activities, and we talk about things we can do inside the classroom and across campus and what we can do globally. Because at our university, we're a small university, but our representation is of 44 countries or more. And we serve as the perfect microism of this international setting. And so we're trying to embrace cultural knowledge and cultural competence ourselves so we could bring that into the classroom, because it's not a cookie cutter experience. You cannot just teach people the way you want them to be taught, because it's a student-centered environment. It is not a teacher-centered environment. So I just wanted to add that.
Thank you, Dr. Alexander.
Also like to add, here at Langston University, our students who are nursing, public health, and healthcare administration students, they have to take a course where they learn about the health disparities, they learn about the culture of different populations, because that's so important, because when they go out to work, they got to have an understanding of how do you approach certain populations, how do you teach them, how do you understand them? The health disparities, what type of disease processes might you see in that particular population? So they learn that, and they implement that as part of their care for the clients that they see out in the community, the clients that they see in the hospital setting. So I am very, I love the fact that here we don't shy away from the discussion about cultural competence. We don't shy away from the idea that there are disparities. You mentioned social determinants of health, all of those things that we don't just talk about it. We want our students to be able to implement it. We want to look at the outcomes. How does the students practice when they get out into the healthcare field as nurses, as public health graduates, as healthcare administration graduates? Again, We don't want them just to check the box here. We want them to use what they have learned.
Great. Dr. Ketchy. Thank
Yeah.
you, Dr. Hunter.
I have to add, because as you are talking, I have my students sometimes complain because there's an assignment that I give them and it's a discussion. And in those discussions, some of the things I hear, it's so difficult to know everything about everybody and every culture. And I say to them, what you need is cultural intelligence, right? The ability to relate and work effectively with people from different culture, different background, with different perspectives. You don't have to know everything about every culture, but you have to be aware of your own biases. You have to understand that the only way is not your way, right? The only way of learning is not your way of learning, or the only way of teaching is not your way of teaching. That the inclusive contributions from the people who are in your environment is crucial. It's like trying to sell something to someone. You can't sell me something I have no need for. And if you think I need that, you have to convince me in a language that I can understand, right? So really is understanding my own perspective of what that thing is. But the other thing that I see, or that I think, affects how inclusive we make people become, or how people might be, is, understanding the root cause, understanding the root of the problem. Is that you have to first agree that exclusion is present. You have to be aware that some people, some individuals, some perspectives are being excluded from the decision, from the conversation, from the classroom, from the learning process. If you don't think that exists, you are not going to make any change, correct? So you have to first, okay, some people's perspective are excluded. Some students in this class don't feel like they are part of the classroom. Some faculty don't think that, their own perspective of how it needs to be done. Or some patients' view of what healthcare should look like for them is not being there. So I think that's, that's one of the things we have to first get to. And then be culturally intelligent. Because when you are, then you don't have to know everything about everyone and every culture in this world. And because we know there are over 1 million of them.
Right. I think that another way that we could say this about culture is the culture humility, right? To make sure that we are listening, that we are able to understand that is exactly what you're saying. We have to assume we have to accept there is an issue, so that we can actually then work on the issue from all these very different perspectives. Dr. Array, I saw you had your hand up.
Yeah, no, just think about just the clinical application of this. One of our faculty in our Morehead School of Medicine, Dr. Brathwaite, when she was a fellow a couple of years ago, she published her capstone paper, was fascinating on the care that are given to patients, and she's a vascular surgeon. Patients who get reconstructive surgery for lower extremity arterial disease versus patients who get amputations, right? Our current department chair, has done, he's a surgical oncologist, has performed very similar studies. He's with the disparities in outcomes and treatments. I think when I was thinking about your question about why does it matter, is because providers that look like the patients need to be able to relate to your providers, because there's so much evidence in the disparity of care. So many more Black patients in the state of Georgia are offered amputation over reconstruction, regardless of pathology, regardless of what they go through. Before I got to Grady, right, in 2017, the trauma surgeons that did a lot of breast cancer, right, which is dangerous to the community, but it's a county hospital. But no patient was offered reconstructive options, even if they could afford it, even if their insurance covered it. And now it's actually, you are supposed to offer every patient with breast cancer, with a breast cancer diagnosis, genetic testing and reconstruction options. But that wasn't even a thing, right? And that was just 2017, right? So it's fascinating how those outcomes are so vast. Patients with gastric cancer do better, right, at hospitals that are diverse, hospitals that have doctors that look like them. taking the same chemotherapy medications, right? There's still no answer to how these outcomes work, but it is very true that it is there. That patients that, and I, again, as a resident, I rotated here in Atlanta at a very, very wealthy white hospital, which is Piedmont Hospital, right? And on the transplant service, something that stood out to me was all the kidney transplant patients. Again, just to get into that hospital, you have to have like the best insurance, right? Just to get in the door. It's not Grady, it's not your county center, but just to get all the kidney transplant patients, the liver transplant patients had PCAs, and they did really well, and they went home on post-op day 3, 4, right? Kidney transplant. Ironically, I noticed as a resident, several of the Black kidney transplant patients who had met all of the wealthy, whatever metrics that a hospital uses, a lot of them were given PO Oxy, some of them Tylenol. And I had to bring it up to her on the 10. I was like, wait, because then what happens is those patients have a lot of pain, they don't mobilize, then they don't have any return of bowel function. They have a longer hospital stay. Sometimes they have a post-op, but then they end up maybe reoperations because maybe they have a renal vein thrombosis. Like then their course is just longer in the same hospital just because of a bias that Myron J. Sims wrote many years ago, which is so big debunked, but it's so prevalent in medicine that Black people do not feel pain, right? And no matter almost 100 years today, that myth still exists. And even in trauma, I'll see many times people are like, just place a chest tube. There's a young man, he has a pneumothorax, just place a chest. I'm like, no, give him local.
Yeah.
It's interesting, but it still is so prevalent. But it's just about the disparities and how patients do when they're in a hospital with providers that look like them.
Correct. I think you've hit on several really important parts of why I think this is so important. And obviously there's the ethical piece, is the right thing to do, is the knowledge that we gain when we have diverse population as students, as teachers, as it's the outcomes as well. But there's also a financial impact. I read recently in that, I think in 2023 they did, the National Institute of Minority Health and Health Disparities did a study, and it showed that an estimated 451 billion years was the cost per year was the cost of disparities for the United States in general, and that was 2023. And so when what you're talking about is exactly that, because when we see disparities, right, we see that effect immediately in our patients, the access to care, the prognosis, the hospital stays. It impacts everything in our patients. Thank you for your story, for bringing that up. Dr. Alexander, I see your hands up.
Yes, because as you can see, we're all so passionate about this. And so Dr. Array, when you said that, that hit a point with me, because I often say that we have a healthcare system disconnect. We really do. And why I say that is because we in educational institutions sometimes tend to mirror the healthcare systems in equities, and it interferes with the training. And I see that so much and I'll give you an example. I'm sure y'all have heard of these OER references where they now want you to use these free textbooks and materials. Well, there's an old saying, be careful what you give for free. So what happened was, I and another colleague of mine, we sat in on, first of all, we asked to be part of it, to develop it, and they did not allow us to be part of it, okay? This was here in Texas. But what happened was, when they decided to go ahead and do it, I'm just gonna say it was an all-white crew that did this whole thing. And so when we watched it, I am Black and she is South Asian. And we're trying to figure out, where's the diversity in this? All these case studies you wrote, there's not a case study about anybody else except for the average white person that has access to care and access to financial gain and so forth. And so we have to think about that too, because if we're not using the right resources, then what we're doing is we are creating these biases. We are creating these stereotypes. We have a project that we're working on right now, and Dr. Ray and everybody else may be interested in this. We are working on our own innovative simulation virtually that we are creating, and our master students are actually helping to write the case studies. And what we're doing we're doing the case study, same case study for every ethnic group and every nationality, and watch how students react in different realms. And one of my students, and I'll just say this really quickly because it was just so eye-opening. She's a dialysis nurse, and she said, Dr. A, that's what my students always call me, Dr. A, why is it that Blacks or African Americans are the ones that always end up with end-stage renal disease and on dialysis? Why is that? Why can't we get the treatment that other people get that can keep them from doing that? And then, we talked about it, and she said, and they say it's diet. Well, let's be realistic. African Americans don't have a diet because of the way that we were brought here, right? So we don't have a diet. We had a diet that was created for us. But if we really followed our own diet, it would be fruits, vegetables, and lean meat. So Dr. Array, I just wanted to bring that point forward because I think that it takes a village, and we have to incorporate the partnerships, the advisory boards, the different disciplines, and we have to come together and figure out how to teach our students in a very inclusive way that includes all diversity, and remove these myths and let them see people that look like us take care of them.
That's a really good point, Dr. Alexander. You just brought a few weeks ago, I was in clinic and we seen this lady who has breast cancer, and she was at renal failure. And so I asked her, I was like, what is the plan for transplant? She's like, transplant? She's like, what is that? I was like, yeah. I was like, you've been on dialysis now for about 1.5 years. What's the plan for transplant? And she's like, no one has ever brought that up to me. And then the other resident with me was like, what do you mean, what's the plan for transplant? So we spoke, and I was like, dialysis is a temporary measure. I was like, usually in most, the inclusion criteria is like, if you meet certain criteria, the next step is transplant. That's a definitive cure. And she was just like, no one has ever brought this up to me. And she had the insurance, she met everything, she has the support. But it created a whole discussion now with our entire surgical team, because even our own trainees are taught, yeah, renal failure, you get IJ catheter, perm cath, you get dialysis, and you move on. I'm like, no, there's a 5-year patency failure in all of these things, right? And I was like, that is not the end goal. And so it's funny, like even within my own team, our trainees, they thought, yeah, you got dialysis. Like, and I was like, no, I was like, the goal, the next step is transplant. I was like, that is the answer to renal failure. Then we had a whole discussion about, well, who meets the inclusion criteria for transplant? Because sometimes you have the insurance, but some of it is if you don't have social support, what does that mean, right? Who defines what social support is? And this is a committee, and the Kidoki guidelines are so vague about this, who they approve. So even if you had the finances, there's so many barriers. If you've missed some medications in the past, you don't qualify. Like the inclusion criteria beyond the finances is still so vague that most patients don't even know about it, and it's not even promoted in many communities. And yes, way more African American patients get dialysis access creations than transplants within the same healthcare system that we are in. And it's fascinating when we do these studies and you think it's a multi-center study. It's one institution and the results are vast. If you're Black or of color, you have very different outcomes. Same doctors.
As I sit here and I listen to all of this, I have heard this, known about it for years. I think when we talk about change in curriculum, we need to make sure we're educating our students, our graduates. They're the ones that can go out there and help make the changes. I saw the comments in the chat about WAL when you were saying, Dr. Ari was saying about people not getting information. We got to get the information out there. We got to empower our students, our graduates, to speak up. Because if we're teaching diverse populations, and many of us are, they got to speak up and ask the questions. Don't sit back and be silent and wonder. I would ask the question, is there a reason? Educating our clients, we're more than about just doing things. We got to educate them about asking for what they want.
Dr. Hunter, I do have to say though, in educating the students, we also have to educate each other and our colleagues,
Yes.
because we have many colleagues that don't understand it, don't get it, and don't want to get it. And so we have to make a concerted effort to make sure that we are providing that mentorship. And Dr. Ketchy and I have done extensive work on this and talked about this, because if we're not mentoring our own and we're not bringing awareness and we're not publishing what's really happening out here, then it's not going to change, because the students have to see it before they can believe it.
And I agree,
Yes.
you know, that we do need to educate our colleagues. And that's part of that education. When I say our students, our graduates, that's part of educating our colleagues, because our colleagues can't teach it unless it's been brought to their attention. So it's all inclusive of not just students, graduates, but our colleagues. I do agree.
I do have to say something.
Can I? Oh, go ahead, Dr. Kidd.
I
Go ahead.
wanted to add, talking about educating our faculty. Come on now. We are all educators, right? Like I said earlier, you have to admit there is a problem first. If you don't admit there's a problem, there's no teaching somebody who does not know what they don't know. It is that simple. So they have to be willing to go learn. The same thing is true for, if you have an exams, what do? You study. If you have an area of deficiency in your studies, you've done those practice exams several times, and every time theory comes up, you bomb it. You do more on the theory aspect of it, because now you know you have problems in that area. And as faculty, it is our moral and ethical obligations to understand what we don't know and then do better, because we owe that to our students and to our patients. But also one thing else that I wanted to talk, I do want to mention is that, historical, because what Dr. Array talked about, what Dr. Alexander talked about is this, that social historical process. It keeps going, because what you need is a chain. You need to have a break in that chain. Until you have that break in the chain, which is probably why we're having this conversation, right? So we can begin to, put kinks in that chain so it can be broken somewhere is really, really important. But, again, in the curriculum, what do we see every day? Add something more, add something more. And everybody who teaches any program that ends up in licensing is focused on this huge content that they have to, teach, because, they need to pass the exam. But you know what is funny about the exam itself? That half what we teach doesn't even show up in the exams. That if we are more conscientious of the way we teach and use some of the opportunities we have in the classroom to introduce this, a patient who have kidney failure or kidney problem, the end result is not dialysis for life, that they also have to consider. People don't have those conversations with the student, right? What they talk about is the care you provide to somebody who is in dialysis, without saying to them, it's okay to ask your patient who is on dialysis if anybody have ever talked to them about transplant. The next time your surgeon or your doctor comes in here, you need to ask them, hey, doc, do I qualify for transplant, or can you talk to me about that? We don't tell our students that it's okay when they graduate, or even our student, to say, you have the right to ask your physician or your nurse a question about your care, and that they are under the obligation, a moral obligation, to answer those questions or to refer you to somebody who can provide you something about that. And in a language and at a level they can understand. Because when you are ill, big grammar does not work. If you're talking to me in a language I don't understand, and you're using colloquial languages that make no sense to me, it's gonna go in one ear and the other one. All I'm hearing is, I have kidney failure, I have kidney failure, I have kidney failure. Everything else you're talking about, I do not get it. So you need to give me the time later on to understand. And that's how you could, begin to make some difference in some of the care we provide to our patients.
Thank you, Dr. Ketchy. I wanted to pivot a little bit and talk about like specific support system and resources that you can recommend or that you think are important to foster this sense of belonging, this sense of being part of for our students. And I wanted perhaps give the chance to Dr. Langley if he has any thoughts on that, or please feel free to jump in otherwise.
Certainly, you know, as I hear a lot of the conversation that's been going on, and I listen intently, and a lot of factors that have been brought to light are things that we're aware of, and things that are clear that the African Americans lack this, and there's certain things that are detrimental to certain populations and students. But I want to borrow from a cultural anthropology concept, actually two concepts for a second: emic versus etic. You know, what can we do? If we look at from an emic perspective, EMIC, which means culturally specific. So being aware, what can we do? Get to learn things about others' culture. Incorporate in your explanations, do some research, find out about your patient population or the learned population which you're learning, to read up on what cases are prevalent. But be careful not to generalize. Be careful not to oversimplify. Be careful not to say that just because diabetes is rampant in one particular population, that that's the case in all instances. You know, we have differentials for a reason. So being aware from an emic perspective means culturally specific, looking at things from their point of view. Etic, ETIC, culturally universal. Now, on the contrary, there are certain things that are universal. There are certain illnesses that are prevalent in certain communities, and you need to be aware of those things in terms of administering medications that may cause side effects. And so you need the awareness of both. And there's a concept we haven't really brought out. We've talked a lot about cultural competence, but we haven't really mentioned cultural encapsulation. And that means to be closed-minded, to only view certain patient populations as only being able to deal with certain things, or on the contrary, they can handle it. They can deal with a lot of pain. Their pain threshold is high. That's cultural encapsulation. And so three conditions that I think are prevalent in helping advance in terms of services, which was the initial question. Number one, develop the skill of unconditional positive regard. This is a basic humanistic trait. And that means simply to understand and respect people from their point of view, right? And that's, last time I checked, that's part of the definition of empathy, is being able to understand things from another person's perspective. You know, and a lot of times we offer sympathy, which is understanding from our perspective, but not so much empathy. Second condition, I would say, is genuineness. You know, we talked about genuine inclusivity and how do we do things without checking boxes and just going through a process. I hear the phrase be real, but what does that really mean in terms of practice? You know, talk to your colleagues, inform your colleagues. These are all things we hear about, but for what purpose? Is it for the purpose of helping patients? Last I checked, the whole notion of helping in healthcare was do no harm, benefit, beneficence. So be genuine. And then lastly, you know, be accurate in terms of how you go about treating certain patients. Ask questions. You know, physicians oftentimes, healthcare providers oftentimes are the experts. We know, but keep in mind that the patients are also experts as well. They're experts on how they feel and what they're telling you. Sometimes they have high context communication by which they'll communicate non-verbally or through actions, and you have to interpret those ambiguous stimuli. And then sometimes they'll have low context. It hurts here. Oh my gosh, my head is, oh, you'll be fine. Take a Tylenol, take an aspirin. Listen to what they're saying. So those are just some things that I think are important in terms of advancing services to help people get better.
I'd like to add something, Dr. Langley, when you said that, you know, patients being, you know, knowing more about themselves than we do, and empathy. And I couldn't agree with you more in that regard. And even understanding who are you talking to, because if you and I are patients, we're gonna be different, right? And sometimes you find yourself being spoken to like somebody who knows absolutely nothing, because nobody have taken the time to ask you who you are and at what level you may need, whether it's education or care, or maybe even have to, you know, address you and approach you. But the other thing that I wanted to add, when you say, how can we teach people, right? The question, Dr. Ilon, is like, you know, how can you make it work? What can you learn? I wanted to share with you something I received. My sister is always sending me stuff. So yesterday she sent me this thing on WhatsApp, and he said, you know, the best explanation of lipid profile she's ever learned. So it's not mine. I just wanted to share it. She said, imagine our body is a small town. The main troublemakers in this town are cholesterol. They have some accomplices too. The main partner in crime is triglyceride. Their job is to roam the streets, causing chaos and blocking the roads. The heart is the city center of this town. all roads lead to the heart. When the troublemakers increase in number, you know what happens. They try to disrupt the heart's function. But our body, the town, has a police force too. HDL is the good cop who arrests troublemakers and put them behind bars, the liver. The liver then throws them out of the body through the drainage system. However, there is a bad cop too, which is kind of funny. The LDL, who is power hungry. LDL releases the troublemakers from the jail and put them back on the street. When the good cop LDL is outnumbered, the town becomes chaotic. Who likes living in such a town? So she goes on, but I wanted to stop there, right? Can you imagine how many of your students or your patient who will remember this story if you are trying to explain that concept to them as to something that is happening to them if they have had problem, if they have high cholesterol or something like that? It is learning. I bet you this was from a very lay person who finally got it, right? But you can find inspirations from all spheres of life from anywhere. And you could ask for permission to adjust them to suit your population or to adjust them to suit whatever you're teaching in your classroom. It's called being open-minded and willingness to learn something new and different.
I just
That
want
was amazing. Go
I
ahead,
want
Dr.
to add
Alexander.
one thing to that, Dr. Ketchy, and that is, it just brought to mind, that's beautiful, by the way, and you tell your sister to get that published. But what I wanted to say, and this is going to be very quick, is it reminds me of when I was a young nurse working in the clinical setting. And I had a doctor tell me one time, because we were talking about some of the same things that we're talking about. And to your point, Dr. Array, what you were saying about trying to understand what's going on with the patients and the patients understanding what's happening with them. He always said, you know what the key is? The key is to treat the patient and not the textbook. And when we start doing that, we will understand how to bring diversity and how to bring centered care into individuals instead of trying to fit them into the mold. And that's what that made me think about when you read that.
I like to add to that because when we do educate our patients, we hopefully we do, and we tell them, give them the resources that they need. We need to listen to them. We need to hear what they have to say. You know, what questions do they have? Are we always doing all the talking? Are we asking them, what do you want? And so I think that's very important as we talk about inclusivity. Are we really including the voices of our clients?
I think that's a very important point for sure. Thank you. What about the students? How can we support the students?
I was just gonna say that, because when you're an educator, if you don't work in the clinical setting anymore, your students are kind of your patients, and they're not patient, I'm just saying. So that what we owe as practitioners to our patient becomes what we owe to our students as people who work in an academic setting. And I'll tell you, one of the most demoralizing things you can ever experience as a student is when you have similar problem with another student or a couple of students. And you as a student feels like nobody's listening to you. Your concerns are dismissed, like it doesn't matter. Or the best advice you could be given is, are you sure you can do this? It's really hard. This is really hard. Are you sure you can do this? Nursing is a really tough profession. And this, you think it's hard now. It's only gonna get harder as you progress through this program. And another student is told, oh, don't you worry about it. Come to my office when you have a moment. I'll go over that with you. Oh, don't worry. You just need 0.24 points. I'll give you 0.24 points. You'll be all right next year. You just focus on what you need to do. Now, that's not inclusion. That is pure exclusion, right? And faculty, and I'm not saying all faculty are like that, but if I get $1 for every time I witness that as a faculty member, or anytime a student tells me this story about their experience, I'll be a millionaire. for every time I hear that kind of story. And those stories are not coming because they're making it up. It is their experience. That's what they're experiencing. Or when in a classroom, because there are very few students who are students of color. And every time you're talking about something negative, you direct your attention to that student. Or where you expect the student to explain everything about the Black person or the Hispanic person or things like that. They are not the spokesperson for their entire race or ethnicity. And I think that is a way of excluding those students. You're not being inclusive because they are not, that's not what they do. Faculty, again, we have a responsibility to learn. We have to be willing to learn. Cultural humility, you brought it up earlier. You have to know what you don't know and then seek to make up for that by learning. And don't be afraid to fail. Failure is okay, but the thing is, start again, because that's what we do and should be doing.
Thank you. Dr. Alexander, you have your hand up?
Yes, I wanted to say also adding to that, when you talk about students, I like to say we have to invest time, talent, and treasure. We do. And how do you do that? You show up, first of all, and you are present. See, some of us show up, but we're not present. We just show up. And being present for students, you have to be everything to them. You have to be the mentor. You have to be the coach. Sometimes you even have to be the mama. You do, okay? But you have to advocate because you are the voice for them. And you have to advocate their needs, not only for just the underrepresented peers or students, because you don't know that. You can't determine who's unrepresented, right? And so we have to foster that environment where we have mutual respect and support, and we have to get to know our students. I shared this actually on LinkedIn just recently. I was coming back from a speak that I was doing in Pittsburgh, and fast forward, my seat got messed up on the plane and I ended up in a different seat, and my husband and I were coming back together and he sat somewhere else. And I said, you know what? I'm be humble about it. I'm not even gonna make a big deal because with everything going on, I just want to get home safe. So I sat down. So fast forward, this young lady, she was sitting in the middle seat. So I guess she was asking the young man to move over. And when she sat down, I immediately recognized the voice. I'm very bad with names, but we locked eyes and she said to me, Dr. A. And I said, I know you. And she said, I know you too. And she told me that she was in my, when I was teaching in the licensed practical nursing program. So this is like almost 20 years ago. She said, I was in your LPN program almost 20 years ago. And I said, really? And I remembered her and then we started talking. And so anyway, the gist of the conversation went to, I said, well, what are you doing now? And she said, I'm a nurse practitioner. And I said, oh my gosh, I am so proud of you. I don't know what to do. And she was telling me what she did. And she said, no, I am so proud of you. And I said, what do you mean? She said, I'm so proud of you because we are what we are today because of you. And she went on to give me accolades about my teaching. And she reminded me, she said, you know, it's 7 of us that talk about you almost on a daily basis that was in the class because you motivated us, you mothered us, you instilled in us what we could do. She said, I was from Ukraine and I came here as a child thinking that I would never get ahead. And a lot of the instructors told me I couldn't do it because I don't talk enough. And you told me, don't worry about talking to them. Talk enough to the patients so that they can understand what the needs are and how you can help them. And she says she still remembers that to this day. Fast forward, she does intake for children that are abused and veterans. And she said, if it was not for me telling her that, and if it was not for me instilling her that confidence, that she wouldn't have that. So I sum that up to, we have to give our time, our talent, because that is the treasure. I just want to share that.
Thank you, Dr. Alexander. Dr. Array, I saw your hand.
Oh yeah, no, I totally agree with everyone. I think it's interesting. So, from like medical student and surgical trainees, we sort of building on all this, we're very blunt and aggressive, right? In some of our techniques. So we always remind any of our surgery residents. So there are only 2 HBCU surgery residency programs in the United States. That's Howard University Hospital and Morehouse School of Medicine. Those are the only 2 HBCU surgical programs. And we always tell all our students like Black surgery residents are 5% of surgery residents in the United States, right? Yet they represent about almost 20% of those that are dismissed from institutions, right? That number is crazy. But we always tell residents right off the bat, even medical students, are like, this game is skewed against you, right? It is not a fair playing field. Day one, that's why I tell residents, like, this is not a fair playing field. Dr. Charles Drew, the father of the blood bank, right, is someone that we quote a lot. And one of his famous quotes was that he said, excellence in performance will overcome any artificial barriers created by man. And so we tell all our residents day one, and even some of our Kaplan students, when we had the mentor thing, they would come to Atlanta and we'll rotate together. And I tell them, I say, you have to be on top of your game. You have to know your patients really well. You have to perform, because the other student, when a white resident struggles, program directors and chairs say, oh, it's okay, give them time. Year 4, year 5, they graduate them. Oh, just give them time. When a Black first-year resident struggles, the answer is, he's not meant for this. She's not cut out for this. She's not supposed to be here, right? The response is there. So we tell the residents right off the bat, this game is skewed against you. So you have to perform. The other thing that was really changed the game for us, which is where I am in my career now. So I was talking to my chair and several other chairs. Most of us are, for some reason, I don't know how it happened, we're all military. But we realized that there's no way we can change the game or change the system from being on the outside, right? And so there are about 9 of us who are all pushing to go into hospital administration. One of my long-term goals is to be a CEO of a large healthcare system, because there's no way, like, all these papers are out there, right? You just Google renal transplant, all these papers out. We have published so many. No one cares, right? It doesn't meet the hospital budget. It's like, oh, good job, Dr. Ray. You guys have published a great paper on inclusivity. Doesn't change anything because we're not at that seat, right? We're not on the table, so we're on the menu. And I feel as though on the surgery side, where we're trying to change this for our residents who are graduating, and even our medical students, is we have to be at the table. We have to be when those decisions are made. And that's what we have noticed, that we've been hitting this brick wall for many years, but we need to get to the next step. And so even when residents graduate, we tell them for every administrative job that a non-MD gets, that's more penitence. That's more of someone else who does not advocate for you that's at that
For
table.
you.
Yeah.
Correct. Yeah. So we have 2 minutes left. I am really sorry to say this is an incredible conversation that I hope we can continue at a later date. But if you can, each one of you very quickly, 10 seconds, one recommendation for our audience members or for yourself of something that they can do today to start improving these issues. And Dr. Hunter, if you want to give us a start.
Yes, I think that it's important that when we talk about inclusion, that we are present. And a lot of times we think, 8 to 5, Monday through Friday. We need to create an environment where our students know it's okay for them to come to us, to ask us questions. I think we all can do that. Just be open. Listen to them. Just know that maybe you may have a question on a Saturday or a Sunday. It's okay that you ask your question. They got to feel comfortable, because sometimes they come in and they have been left out of other places. We got to make them comfortable that they can come to us.
Okay, openness. Thank you, Dr. Hunter. Dr. Array, very quickly.
Just don't stop fighting.
Don't stop fighting.
Stop fighting.
Dr. Ketchy, very.
Know yourself, be honest with yourself, and take a look in the mirror.
Humility, honesty, great. Dr. Alexander.
I would say be in the room where it's happening, advocate, and make sure that you are loud about it.
Dr. Langley.
Develop the skill of withedness.
All right, excellent. So that is all for today. Thank you, each one of you, for your insights, for your time. We should continue this conversation. Thank you, everyone who was here today. This is it for now, but we will continue. Again, have a great day. Have a great week.